And Dr. NIVEAN is one of the directors for academics of MNI Hospital based at Chennai, and is a very well-trained ophthalmic surgeon, both anterior and posterior segment surgeries. And he's going to show us a very challenging case.
Thank you, ma'am. So respected teachers, senior ophthalmologists, my dear friends. So I'm going to show a case of Phaco and a case of pre-existing PCR. So this was a diabetic retinopathy case which underwent intravitreal injection, and there was a lens touched. And after 2 months, they developed a flowery posterior capsular cataract. So we had to do a Phaco specification, keeping in mind that there could be a pre-existing rupture. So just going to go through what are the precautions that we can take while doing anticipating a pre-existing PCR. So the first thing would be the rexes. As we all know, just try to aim for a slightly smaller rexes, maybe a 4 or 4.5 millimeter rexes, for the reason in case we want to keep the lens in the sulcus or have an optic capture. The second thing is we avoid hydrodissection. So hydrodelineation is preferred. Making sure you go into the substance of the nucleus and then inject. And you can also do it slowly and in also multiple quadrants, so that the endonucleus gets separated from the epinucleus. As you can see here, just going into the substance, as it's actually a slightly softer cataract. Phaco, there's no particular choice of step, but here, because it was being a soft cataract, I just wanted to hold one of the edges and actually flip the whole nucleus or the endonucleus first. As you can see here, just using high vacuum and very minimal power. The only thing here is make sure that the chamber does not fluctuate like how we do in a normal Phaco. We just have to slow down our maneuvers so that there is no fluctuation of the chamber, which in case if there is a rupture can extend the rupture. So far everything was good. So the nucleus is out now. So here again, as we do for any PCR cases, always inject viscoelastic to make sure the anterior chamber is filled, because only when the anterior chamber collapses, and that is a chance when the rupture can extend. I usually prefer the bimanual IA. So keeping the irrigation steady, I'm actually starting from the area away from the suspected area of PC touch. This again helps in reducing the amount of cortex or the things that I can deal with in case there is vitreous that is prolapsing there. So I'm removing the cortex first from the other end. Here again, trying to be gentle and just stripping the cortex, bringing it to the center and then aspirating. So once it is done, as you can see, diabetic cataract, sometimes the cortex can also be sticky. So that's the area where we are suspecting, which we're coming last. So the last bit of the cortex. Just below that, we can see there is actually a defect in the PC and the flap that is floating, which you can appreciate right now here. So, but now we have the nucleus and the cortex out, but here again, make sure the anterior chamber is maintained. So again, viscoelastic to fill the bag. Actually, it doesn't have to be in the anterior chamber as long as the bag is filled. And here because it is a small rupture, I'm going with a single piece lens into the bag. So here again, I know there can be 2 ways of managing it. Some people who are experts can actually do the posterior capsular rexes first, but then I wanted to put the lens into the bag first. And then yes, we always tell a tear is always a weak area. So it's always better to convert these tears into a posterior capsular rexes. So using the forceps, just converting the PC tear here. Just a model content that I have the bag, the IOL already into the bag, and then trying to complete the posterior capsular rexes. So make sure always the force is towards the center, and you have to aim for a slightly smaller posterior capsular rexes. So that's the last tag. So once that is there, you can see I have the lens in the bag and the circular posterior capsular rexes. So here, being a retina surgeon, in this case also we had planned for an intravitreal, and you could see those anterior vitreous space, and they had some fibers there. So this is just to check there is no vitreous always, just putting the tricot. But then just you can see those pigments on the anterior vitreous face. So here what I had to do is we introduced a trocar here. So it could be controversial here for discussion, but then it is always better to clear the vitreous just behind the lens also. So here again, I don't know, most of the anterior segment surgeons are using the 23 gauge assisted vitrectomy in case when they have a posterior capsular rupture. So always nowadays, the new concept is the pars plana management of PCR is definitely better than the anterior approach. So once a limited anterior vitrectomy is done, I'm going to use the same 23 gauge trocar to inject the triamcinolone acetonide in this particular case. And then the trocar is removed. And that is the end of the surgery. So once again, thank you, Chitra ma'am and ARC for giving me this wonderful opportunity. Thank you.
A question to you, NIVEAN, because you're the retina person. When would you think should be the ideal time following between an intraarterial injection and a lens touch to avoid to do a phaco surgery? What I'm trying to ask you is, what should be your interval? It was a very early cataract. Would you believe that if you delay it a bit, there could be some amount of fibrosis which could happen in that area of weakness or where there has been a lens touch, and you might not get a PC extension there?
That is correct, ma'am. But depends on case base. But this particular case, because it was on the visual axis, it was disturbing the vision of the patient. The second thing is sometimes when the cataracts can progress very fast in these kind of diabetic patients, and when there is a traumatic touch there. So once it slightly becomes denser, it is even managing the nucleus becomes more difficult. So maybe there's no clear-cut timeline. So one, maybe once there is a drop in the vision, and two, when you want early intervention.
What is the pearls which you would advise not to have a lens touch in the primary situation?
The correct procedure, because the using the correct measurements, because sometimes we take it for granted and just go in without measuring. So always 3 millimeters or 3.5 is safest to do it, and always direct it towards the disc, like as if you're going inside, because sometimes when we tend to do it like a phaco thing, we go slightly parallel. So always make sure your injection is going towards the disc. So that way you can avoid the lens touch. And after you go 3/4, just make sure you can see that above the needle there, and then inject. It doesn't have to be a blind procedure. And then come out also on the same way, because sometimes after we inject, to come out slightly superficial. So again, we should make sure that we go in and the same way we come out also.
Yeah. Yes.
Just
yes, Anagha?
Yeah. Dr. NIVEAN, how did you detect that it was an injection which has caused the PC defect? Did you do an OCT or did you immediately see it next day? Just as a listening to all our viewers.
No, ma'am. It happened in the hospital itself. So on table itself, we had noticed it.
On table, you saw that there was a lens touch.
By my retina consultant, but we waited. It took at least 2 months because initially it was. But
okay, another thing.
There was a touch, because most of the time, sometimes a touch necessarily does not have a tear also. So that's why I said just suspecting the rupture. We are not sure that it is a rupture.
But on OCT, you could have seen the defect, no? If
I think they say they can see it, but sometimes it is very difficult.
Yeah, there are some OCTs which you cannot.
The other important question which I have is,
yeah.
The other question I have is, as a routine, would it not have been easier to have done a PCC and then placing an IOL? I do believe placing an IOL sort of tamponades any possible vitreous coming forward. But I just wondered, would it be not easier to do a PCC?
This was done a few years back. So Ramamurthy sir asked me the same question once I presented. It was like, actually, maybe I was not confident at that time even though I was doing a posterior capsular rupture tear. So I felt safe keeping the lens and going under the lens. So, but actually it can be done before placing the lens also.
Yes. Dr. Sanjay, you have anything to add?
To do it also sometimes.
Yeah. So like NIVEAN said, that the chamber stability is very important when you're doing this kind of a procedure, and you're taking all the precautions that you would take when you're doing a posterior polar cataract. So it's kind of similar with a suspected PC rent, without a PC rent, right? PC defect. So what I do is, in such situations, I use an interior chamber maintainer. So I put an additional side port entry, put an interior chamber maintainer attached to a bottle height of, say, about 40 centimeters. That gives me an IOP of 30 all the time. So instruments in and out of the eye, there's no problem. The chamber is stable. So the chances of the posterior tear extending because of instability or the whole capsule nuclear diaphragm coming forward and causing the rent to increase, those chances are minimized. So that is one additional thing I would like to do. Otherwise, your steps are pretty good. Of course, again, like Dr. Chitra said, once my chamber is stable, I would have straight away gone for a posterior CCC. And it is in direct visibility. And if I do it, probably I would not have required a vitrectomy, because your vitreous wasn't actually disturbed. It was just a red.
No, not at all disturbed. And I don't know why he went
But
in and put a trocar and did a vitrectomy at all. Because he's a retina guy, he did it. I don't think it's a message for the audience. What do you say, Dr. Basin?
Yeah, the same thing. That two things are there. I would have preferred to do do posterior capsular access first, and then put the IOL. And I will do it through the side port, through the paracentesis, because that will not enlarge the axis too much. And secondly, I will not encourage anyone to go for the vitrectomy through the posterior route if you are not trained that way. And that is a blind procedure, basically.
Yes, true.
So I think, shall I add,
And in
ma'am?
this particular case, it was not required also, what I personally feel.
Yes, Dr. Shalini?
Yeah, actually, sometimes history is also very important. We had a similar case which came to us, and there was sudden onset, absolute loss of vision after intravitreal injection. So, and it was absolutely white cataract. And when we did anterior segment OCT, we could not see any defect also there. But as very rightly pointed out, that we should anticipate in such patients that there might be a pre-existing defect, and we should actually deal it like that only. And I think he did a wonderful job. But yes, I would agree regarding capsular access PCC. I would also do it before putting the IOL, the PCC.
Wonderful surgery, Dr. NIVEAN.
Thank you.
Do stay connected. We would want retina opinions on some of the other cases.